I was invited to talk about youth with sexual behavior problems. I have worked in this area since '94. At the University of Oklahoma Health Sciences Center, we have programs started in the '80s for adolescents with illegal sexual behaviors, and then did a randomized clinical trial with school-age kids, 7 to 12, with sexual behavior problems, and began getting referred younger kids, and so I started a preschool program and done some research on that. We've also done some follow-up, 10-year follow-up with the group. So I'm here to talk with you about the population, share what I've learned from working with these families for a long time, and share what I've learned from other researchers. This is the last talk of the day. You've been sitting all day long, so feel free to stand up and stretch if you need to, ask questions. I'm not sure, any questions you have throughout the talk, feel free to just chime in. And our contact information is on your PowerPoint. If you want to reach me, you can email me or call me. Email is probably the best. So what we'll be talking about today are children with sexual behavior problems, or adolescents with illegal sexual behaviors, another term we use, but I'm going to focus on kids 12 and under. I like to use the term children with sexual behavior problems. I'm very deliberate about the terminology. Part of it is to recognize these kids are children first. And the sexual behavior problems that they may be showing, I'll talk with you about some of the origins, but it's important to distinguish them from adult sex offender work. Sometimes they will be grouped with pedophiles, or be called perpetrators, or mini pedophiles. And that brings a belief and philosophy and thinking that takes things we know about adult sex offenders and put them on young kids, and there really is not a relationship between those two groups. So that's why I use the term here. Although most parents want to believe their kids are not sexual beings until they're at least 18, preferably 25 and married, the reality is that kids develop sexually in utero. There's actually research of particularly boys touching their private parts in utero. So we know that there are typical sexual behaviors that occur throughout childhood that involve private parts, and it's considered normal. It's part of growing up. It's not considered harmful to the child or to the other children. We do know from particularly the research by Bill Friedrich that there are cultural influences, that what is typical in one group may be a little bit different than other groups. A couple examples, some of the research he had done was in Northern Europe, where they found that moms reported that their young children had more frequent kinds of behaviors than in the US. That the behaviors that did occur for our young preschoolers, such as walking around without clothes on or touching their mother's breasts, were found to happen more frequently in Northern Europe, Netherlands, Finland. And it was attributed to really different beliefs about modesty, privacy, sexual attitudes. In addition, Thigpen did some research here and worked with a conservative African American community, very religious community. And they found less frequent sexual behaviors of the youth than normative samples. And so in communities or cultures where privacy is very enforced, modesty is very enforced, you may see less sexual behaviors. What you don't see in any normative sample are aggressive sexual behaviors, coercive sexual behaviors. And so we'll talk about some behaviors that would never be considered normative. Sexual behavior problems are child-initiated behaviors involving private parts in a manner that's developmentally inappropriate or potentially harmful to others. I put child-initiated behaviors is because at times we would get referrals of kids who were sexually abused, and they would refer them for treatment for sexual behavior problems. And although those kids do need treatment, I would not label them of having a sexual behavior problem. What we're looking at are when kids are initiating behaviors with other children. Have you seen this in your caseload? Do you have kids who act out sexually with other kids?
Well, what about kids that have been sexually abused and then they develop sexual behavior problems as a result?
Yeah, and that is one of the origins of sexual behavior problems. In fact, when this field began to really recognize, it was believed all the kids who act out sexually had been sexually abused, or how else would they have learned the behavior? We've learned since that that's not true for all of them. But a large subgroup of kids with sexual behavior problems, how they learned about the behavior is they were abused themselves. How young of a child have you seen with sexual behavior problems? 9? Yes?
The case I had, I think she was 2 or 3.
Yeah.
Lots of self-manipulation.
Harming herself is part of it?
Over long period of
Yeah,
time.
yeah. Yeah, again, I run a group. I have constant referrals of 3, 4, and 5-year-olds with sexual behavior problems. And these aren't kids just with boundary issues. These are kids who are touching themselves and other kids' private parts repeatedly. In fact, preschool kids, when they have sexual behavior problems, it tends to happen a lot because they're at a very impulsive age at 2, 3, 4. Whereas the school-age kids, it may happen every once in a while, and they get that it may be breaking a rule, so they're less likely to do it right in front of everybody, whereas the 2 or 3-year-old will do it in the middle of the living room. This is a hard thing to talk about and hear about, especially, again, at the end of the day. So I hope that I'm handling it in a way that you feel comfortable with as you can. I'd like to also emphasize, we call it sexual behavior problems because of the body parts involved and not by the motivation of the behavior. So an adult sex offender's motivation, in part, is sexual gratification. I've worked with hundreds and hundreds of kids. It's not the case with the children. It may be motivated by imitation, curiosity. For some kids, it seems to be more anxiety-driven. It may be part of a post-traumatic stress disorder. So they were victimized, and one of the symptoms of post-traumatic stress disorder is re-experiencing symptoms. You're acting out what trauma you experienced, so they acted out with the other kids. So the motives tend to be varied, but very rarely are they kids who are driven to satisfy a sexual arousal. I can think of 2 kids, boys who were older, where that was more the primary concern. And again, I've seen hundreds of kids. Oh, and the other thing is not a diagnostic criteria. You can't get a diagnosis on the DSM or ICD-9-10 that says sexual behavior problem. It is a symptom of a variety of disorders. So again, I mentioned post-traumatic stress disorder. It could be a symptom also of adjustment disorder. It could also be a symptom of what's called a disruptive behavior disorder, like oppositional defiant or conduct disorder. And we'll talk a little bit more about that later. And the other thing is that it's a continuum of behaviors. It's not like here's normative, typical behaviors, and once you cross this line, it's clearly a sexual behavior problem. And that makes it a challenge for you trying to assess the kid and their needs and safety needs, is trying to figure out, has this moved across the line past being something just typical to be something concerning, or that we need safety planning and treatment and other services involved. I like to have, when I work with families, for them to think about sexual development in the context of all the other areas of child development. And it seems to help them be better at thinking about, is a behavior that they're seeing a normative behavior or typical behavior or something I should be concerned about. Sexual development does not occur outside of the other areas of development. Their language, social development, moral development, emotional development, etc. So one of the things I do is talk with the parents about what do we know already about other areas of development, and then help them use that information to think about what should that mean about typical sexual development. So we'll do this just a little bit right now. I want you to think about preschool kids, 3 to 5 years old. Don't think about private parts. Think about other areas of development. So one question I'll have to you is, how do kids play and socialize when they're a preschooler? What do they do? What do they like to do?
Play house.
Yes, exactly. They play house, they play make-believe, they play a lot of imitative behavior. My family, extended family, would tease me because I would play meeting. My mother had lots of house meetings, so I would play meeting. They also do more fantasy play, so they'll play being princess and superheroes and so forth. What about their learning style? How would preschoolers do if we had them sitting here and somebody up here talking for all day long? They wouldn't do very well, would they? How do they learn? Interactive. They ask questions. They ask lots of questions. They watch. Eyes, mouth. What else do they use in their learning? Yeah, they're all body in it. You know, that's part of that imitative play that you talked about, is that they're learning by looking and asking questions and imitating it. And then how people respond to that will help determine whether or not that's going to continue. They learn this is something I should do or not do. So how do they make that decision? How do they decide, right, I should do this or I shouldn't do that? What helps them with that decision?
Feedback.
Feedback.
Adults and their peers.
And that feedback primarily at the gut level. So it's not feedback of, you know, honey, that if you steal, then the store loses money, and then they can't keep the other employers working and so forth. That kind of feedback won't work. It's more feedback, it's not okay to steal. You have to give it back and have immediate punishments and rewards for good and misbehavior. So I like to think of preschool kids as seek pleasure, avoid pain. This is an important point for this group because a lot of times caregivers come in very concerned about their child with sexual behavior problems, moral development, and perhaps they are psychopaths because they don't understand why their 4-year-old or 5-year-old doesn't feel deep remorse for acting out sexually toward other kids. Well, they don't feel that because developmentally they can't. They're going on seek pleasure, avoid pain. So helping them understand typical normal development, moral development, to help them understand and interpret their kids' behaviors. Yes?
Well, I may not have been as advanced of a parent as you. I think what I've seen a lot of times, the feedback is more anger and embarrassment, and it's like, you know, if they steal something in the store, you get angry and say, no, put that back, and it's not an explanation. It's and it's an emotional feedback, and, and the child sees, wow, that got a lot of energy about it.
Yeah. That's a really good point. So it's not just the words being used, and maybe, and sometimes even more importantly, the volume, the meaningfulness that they're interpreting, how upset the parent got, and so forth. It gets a bit complicated. Part of it will also be how much are they getting Oh, I did something bad. Oh, there. How much are they getting attention in other ways? Sometimes bad attention is better than no attention, so all of that becomes a little bit complicated, but you're right. It's not just the words, but how it's all being delivered. So given all of this information that we know preschool kids are thinking out of their brain about the world and not taking your points of view, or psychologists call egocentric, and they learn best by getting all involved, head, face, mouth, hands, everything, ears, and they seek pleasure and avoid pain. What would that tell you about typical preschool kids' sexual knowledge and behavior? Are they modest? No. So if they're not wearing clothes, are they an exhibitionist? No. They're being a normal preschool kid, right? So when they touch other kids' private parts, what are your thoughts about that? Would that ever happen normally for preschool kids? They're curious. Kids are curious about almost everything, and that includes body. And so mom and dad are changing clothes, or they're changing baby sister. They're looking at private parts. They're curious. They might try to touch private parts, etc. And it's part of that typical growing up kinds of things. The other thing is that they may hear words and not understand it, right? And so their interpretation of words may be different than your understanding of words. So we worked with a girl who came in and said that she had sex on the playground. Alarm. Ask question, what does sex mean? It means when you kiss with the lips. Okay, so it's something that we need to pay attention to, but maybe not as alarming as what I was thinking when she used the term sex. So being aware of how they use the words. So what I'd like to talk about is the part of normal sexual development that is usually the struggle when you're trying to decide is this typical or problematic, is when two kids touch each other, or one kid touches another kid's private parts. How do you know that may have been something from being curious and being part of sort of normal development versus something more concerning or problematic? So if it's typical sex play, sex development, it should have occurred spontaneously, motivated by curiosity, exploratory. Kids can't consent, as we know, but no one's dissenting. No one's saying, no, I don't want to do this. There's no coercion, there's no force. There were two kids, they were playing with each other. Something may have been going on that involved looking under clothes, and they started touching, giggling, and so forth. I have a 9-year-old girl now who is rock and roll girl, who previously was princess girl when she was 4 or 5, and she had some girlfriends over, and they were changing princess dresses. And I walked out, and I walked into a lot of giggling and a lot of slapping each other on the bottom. Was that a sexual behavior problem? No, they were giggly girls who saw each other's bottoms and got curious and were touching each other's private parts, but in a way that was exploratory, spontaneous. I'd never seen that behavior from the girls before, intermittent. And so I took them and explained we have to keep our private parts covered, and it's not okay to touch private parts, so what we're going to do is each put on a leotard, and we're going to wear that, and then you can change princess dresses all you want. In addition, it's going to occur with kids who should be playing with each other already in regards to the same cognitive ability, developmental ability, age. I like for you to think about it broadly and not just age. Because 2 8-year-olds could both be playing together but not be functioning the same level. You could have an 8-year-old functioning as a 3-year-old with an 8-year-old functioning as an 8-year-old. That's different than 2 8-year-olds who are functioning the same. In addition, there shouldn't be strong feelings of fear, anger, anxiety. There might be a little bit of embarrassment after they're caught, but other than that, if it's typical sex play, there shouldn't be heavy emotions associated with it. What do we know about sex play? We know that it happens often. Did I skip one? Yeah, I skipped one. No? Okay, it happens across childhood. It often becomes concealed in school age. And it occurs with people they know already. It doesn't happen with strangers. But it happens with siblings and cousins. It happens between people who are the same sex because that's who they're playing with. And it has no relationship to long-term sexual orientation. It's just who they were hanging out with and they got curious. In retrospective studies, when it was truly sex play, no aggression, no coercion, no force, the adults reflecting back on their childhood conceptualize the experience as neutral or positive. The one inconsistent result is siblings. And my interpretation of the research is that when they're preschool kids and siblings, there isn't a negative connotation with it. But when they get to be school age and their siblings and their sex play, because there's an awareness in our society that incest is not okay, there is some negative reaction feelings to those kinds of behaviors. The other thing that I've seen is sex play between siblings that started as sex play at 7, 8, and then stopped. But then when the boy hit puberty, it happened again with more force and coercion. And the sister was sort of confused because she had participated in the behavior before, but now she's being forced and uncomfortable with it. And that goes more into that falls into sexual behavior problem, not sex play. So what we recommend for parents when it's a sex play is just to calmly give them accurate information, not do long lectures, making it fit the situation, emphasizing things about relationships and respect for bodies and so forth. A lot of times it's triggered by curiosity. If you can fill the curiosity with accurate information, you're opening a dialogue to talk about these topics, which is important for later on. And it lets them know the rules. I mean, society have rules about our bodies. And they break lots of rules. They steal candy from the store. Then you tell them it's not okay to steal. So it's a way to help them learn the rules. We define it more of a sexual behavior problem by some of these guidelines. One is looking at how rare the behavior is. If it's typical sex play, you're not looking at, for lack of a better term, sophisticated adult sexual behaviors. So oral genital contact, penetration involved in the intercourse, that's going to be more rare and be considered more of a problem. Looking at the frequency and the duration of the behaviors. Is it happening every time those kids are together, or did it happen every once in a while? Anytime there's coercion or aggression or force, that is a huge red flag. This is not typical. This is something that needs a safety plan and to be addressed. Often, just like other kinds of testing behaviors that kids have, if parents intervene and give a reasonable information, consequence for misbehavior, typical sex play should not be repetitive. If it continues to occur, even though the parents are giving good feedback, then you're going to be more concerned. We worked with a blended family, and the stepmom of the 11-year-old had given him lots of feedback about his inappropriate behavior. He was masturbating during dinner, and he was peeking into his stepsisters while they were changing clothes or taking the shower. And his parents, stepmother and father, gave him clear rules. You cannot do this. If you need to touch your own private parts, you need to be by yourself in your room, and gave appropriate consequence for that, but the behaviors continued despite that parental intervention. He ultimately was removed from that home because his siblings were very uncomfortable with that behavior. Looking at the reactions of the other kids, do they have high levels of fear, anxiety, concern? That would lead to you being more concerned of this is a sexual behavior problem. And then does it occur between siblings? A single incident of two kids, for example, 5-year-old and a 3-year-old being bathed together, and they're interested and they start poking at each other's private parts, I wouldn't be worried. That would be more typical sexual behavior. However, if you're looking at school-age kids, I'd probably at least be concerned and want to make sure they know about appropriate behavior and rules, and do some more monitoring of their behaviors. Questions? Do you have cases that you're not sure if it would fall in typical or problematic? Yes.
I'm just, when you keep saying developmental, when you have someone in a juvenile case where there might be, 14, 15, 16-year-old, developmentally is 9 or 10, has some type of sexual interaction with another child who is 9 or 10 and developmentally 9 or 10, where do you put that?
That's a problem. And I'm glad you brought that up, because a lot of times people will bring up, I'm sorry, I'm trying to get over a sinus infection, so my voice is going in and out. Kids that have fetal alcohol syndrome, and maybe their peers that they play with are much younger. And what will happen is that they'll play with younger peers, because that's where they are cognitively, and then they hit puberty, and they get curious, and who do they act out with? It's the kids they're hanging out with. It's still considered a problem because those other kids are not at the age that should be having that kind of play with them. And so that is where you'd want to intervene in regards to what's appropriate and not appropriate, how to manage his sexual arousals. And he may not need this kind of full-blown treatment, but at least start with an intervention that's educating and supervision, and I'll talk about a little bit later about the treatment. But that would be alarming. So it's not just developmentally are the same, but if you have kids 4 or 5 years apart, even though developmentally are the same, that would be concerning. Other questions? Any other kids that you can think of that you wouldn't be quite sure where they fall? Another question people will have is how many kids are there with sexual behavior problems? The honest answer is we really don't know. There's some indication there might be more kids with sexual behavior problems than previously. We're not sure if that's because people are recognizing that it's a problem or if more kids are really having this problem. I could talk for days and days and days about what we know about kids with sexual behavior problems, but I'm going to try to summarize it in just one slide. So both boys and girls have sexual behavior problems. In fact, in my preschool program, more girls than boys have sexual behavior problems. That's one of the distinctions that help us understand that they are different than adults with sex offenders. We already talked about culture and societal factors impacting sexual development. They often have co-occurring problems. You'll see they break other rules. So they're in trouble at school for fighting, for not following the teacher's rules, in trouble with the parents for not following rules, tend to be impulsive. They may have trauma-related disorders. They may have depression. In our preschool kids, we'll see a lot of separation anxiety. And we also see a lot of language and learning problems. And I'll talk a little bit more about that when I talk about origins. Kids with sexual behavior problems bring lots of stress for a parent. It's isolating. They don't tend to have many other people they can talk to about these problems. And it's one of the number one reasons, I don't know if you find this true here, for foster parents to ask for kids to be removed. And so these kids end up having lots of placement changes because of these behaviors. They may be labeled with reactive attachment disorder, but I'll say in my practice, I very rarely see a child with sexual behavior problems who have an attachment disorder. What I'll often see, however, are caregivers who, because their misperception of their children, have a hard time attaching to their kid. And we have to have a lot of work with the caregivers to help them see the child as a child and not as a pedophile or as an offender, and be able to reestablish that relationship. And you'll hear when we talk about the treatment outcome how important working with the parents are. So origins. The historical assumption was that all kids with sexual behavior problems have been sexually abused. However, depending on the sample that you're looking at, it ranges quite a bit. Most kids who've been sexually abused don't demonstrate sexual behavior problems, one. And the other is, depending on what group you're looking at, many kids with sexual behavior problems don't have a sexual abuse history. In our school age program, it's about half. And in our preschool program, it's less than that. Part of that, though, is, as you know, it's difficult to substantiate sexual abuse with preschoolers. And so we have about a third who have substantiated sexual abuse cases, but another about 20% where it's suspected enough that you lean toward thinking it probably did happen. But that means about half of them don't have a clear sexual abuse history. Bill Friedrich did research looking at a variety of factors. He had a sample of about 3,000 kids, a little over 3,000 kids, and looked at factors that predicted whether or not the kids had sexual behavior problems. So these were, some kids had sexual abuse histories, some did not. Some had physical abuse histories, some had not. Some of them had sexual behavior problems, some had not. And looked in that sample what predicted sexual behavior problems. And looked at 4 broad categories. Models of sexuality, which included sexual abuse and having families without a lot of modesty. Models of coercion, which was physical abuse and domestic violence. Family adversity, which was mostly a single mom, poor education, low SES, and a vulnerable child, a kid with emotional behavioral issues. The biggest predictor was models of coercion. Most people would predict it was models of sexuality. This fits with the research that we know about the development of disruptive behavior disorders. Is that kids that are having problems following rules that come to you in your courtroom often have a family environment that has been coercive, and they've been raised in an environment that rules are broken. They see aggression, they experience aggression, they see that's how you solve problems. And that thinking about sexual behavior problems for a substantial group of these kids, these are kids who break rules. And one of the rules they break is involved people's private parts. So a subgroup of kids, it appears to be part of oppositional defiant disorder or ADHD. So you'll have kids that are very hyperactive, impulsive, and so they're impulsively running around the classroom, throwing their hands up in the air, talking out of turn, but also on the playground, hitting the other children on the buttocks, or impulsively touching other kids' private parts. In regards to sexual abuse, a couple things seem to trigger more likely to have sexual behavior problems, and that is sexual abuse that occurs at a very young age with multiple perpetrators. And basically that you're having young kids who are learning how do you interact with people is sexual. And so they end up showing those behaviors then at daycare, at preschool, with cousins, and so forth. And so they learn a pattern of breaking the sexual behavior rules. A question people will often have is, if most kids who are sexually abused don't develop sexual behavior problems, what are some of the predictors? Why would some of them develop sexual behavior problems? And I think that's where those child vulnerabilities come in. And that is, we see a high group of our kids having language problems and learning problems. And so when they're experiencing this levels of trauma, whether it be violence or sexual abuse, they don't have verbal and cognitive resources to help them cope. And so instead, they turn to acting out, finding other ways to distract them, other ways to deal with those behaviors. And then family adversity, in addition to those things that I said before, some of the things that we've seen clinically are parents who are depressed and are otherwise unable to adequately supervise the kids. You talked earlier about substance abuse. We do see parents with substance abuse issues, and they are using drugs, alcohol, etc., not appropriately supervising their kids, maybe having sex in front of their kids, letting the TV be their supervisor. The kids are learning inappropriate behaviors and then acting out with other kids. We see supportive and protective factors that help kids, despite trauma, be able to do better and be able to learn the right rules. And so looking at, in the family dynamic, are there ways to help support boundaries, keep them protected from harm, have them have the parental guidance and supervision, and getting open communication. The key thing you'll see here is the caregiver involvement, and that we'll get to that when we talk about the treatment. All right, I'm going to go through some misconceptions that are common for these kids. Are there any questions about the origins? I think people are getting tired at the end of the day. All right, so a big question is, can these kids attend school? What's the school policies here? If the school knows a kid has a sexual behavior problem, is there a standard of how they manage those kids? No standard? Do they get kicked out or homeschooled, or they can be? Well, what we find, most of our kids attend regular public school and do fine without jeopardizing the safety of other kids. What's going to be important is the clinician working with them to assess frequency, how well do they respond to supervision, and the school. How does the school manage recess time, bathroom time, etc.? Can they keep the child appropriately supervised? And most of the time, the kids are able to be maintained in the regular school environment. We highly recommend that. They need to learn how to interact well with other kids. If they're at home, they're often less supervised, less monitored, and aren't learning how to be appropriate with other kids. In addition, most of these kids can be served in outpatient programs. When we get to the treatment outcome research, these will be outpatient treatment programs for these children that we used in the meta-analysis. Decisions for residential should be made on the community safety and treatment needs. What we've seen over time, the few kids that we've recommended an inpatient or residential stay has been based more on their other aggressive behaviors and their inability to be managed in a regular family home environment. So most of these kids will respond very well to supervision and monitoring. They may have to be placed in a foster home because their caregiver can't provide that. A family we worked with, the caregiver was doing okay, but then returned to using crack cocaine. That child needed to be moved to a foster home because she was not able to provide appropriate monitoring for them. Kids who are suicidal would need inpatient. Kids that are showing psychotic symptoms will need inpatient. But most of the time we're able to provide services in an outpatient program. Yes?
You're talking about 12 and below, right?
12 and below, but that research is also true of adolescents. Most of them can be treated outpatient.
this research as well?
As far as residential versus outpatient, yeah.
So adolescent, what age does that go through?
13 to 18 would be what I'm calling adolescents, although they do start, and I should probably call them teenagers because you start adolescence before 13, but teenagers. And my expertise is 12 and under, but I work with colleagues who work with adolescents who report very similar findings that I am reporting here, that most of them can be maintained in an outpatient setting. Often the key thing is getting a placement. So we've had kids who could be maintained in the community, but for example, the youngster I talked about before that was in the blended family, and the 12-year-old kept masturbating and looking into the bathroom of his step-siblings. He actually could have stayed in a foster home or relative care if there were no other kids. He was doing fine at school. They had no complaints about him in school. He was following the rules fine there. The problem is availability of services. And he ended up actually going inpatient because there was no foster home or kinship home available. And so it's tough, but sometimes we make placement and treatment decisions end up merging because of availability issues. It's actually a lot more expensive than foster home to place him inpatient, but there just wasn't one available. And that happens, I think, I don't know what your experience here in Nebraska, but in Oklahoma, particularly with the older youth, it's very hard to place older children and adolescents in foster care. A question often is are we catching adult pedophiles early? Are we catching adult sex offenders early when we catch a 9-year-old having sexual behavior problems with a younger child? The quick answer to that is no. What we're finding is that the kids that we find that have sexual behavior problems aren't, they're going on a different trajectory. And with treatment, and I'll give you some 10-year follow-up data from our research, the recidivism rate, the rates of getting future offenses, sexual offenses, is very low. In fact, in our program, it's 2%. Adolescent programs have looked at it and looking at more 5 to 14% with adolescents of recidivism.
When
Go
you're
ahead.
looking at adolescents, you're getting to an age where they may be brought into the criminal justice system.
Yep.
And prosecuted as adults, where it's a punishment, not treatment situation.
Yep.
Are there many studies that look at the effect of how they're treated, whether it's treatment versus punishment?
That's a really good question. I don't know of such a study. I do know the Office of Juvenile Justice and Delinquency Prevention is now looking at, we have a grant with some folks in Omaha, actually, who will be actually at our presentation tomorrow, on trying to reduce system level impact on children and families and provide early treatment and see if we can get them out of the system and out of the criminal justice system. In part from the administration of OJJDP belief that with appropriate treatment, they can respond and stay out of the system, saving lives and money. The program is looking at not only the adolescent, it's 10 to 14-year-old is this program with sexual behavior problems, but looking at the whole family and also serving the siblings or other family members affected by it as a family and trying to better address reunification issues and timing. If you can't do reunification, how do we get to permanency? So we're really actually looking at that question now with this grant. So to give you some follow-up with the school-age kids, in the early 90s, Barbara Bonner did a randomized clinical trial looking at treatment for school-age kids. They were 6 to 12 with sexual behavior problems. She compared a cognitive behavior treatment to a dynamic play therapy group. At the same time as she was running that program, I was running an ADHD clinic. So I had a group of comparison kids who had behavior problems but no sexual behavior problems. And what we did was match the kids' names, date of birth, social security numbers with our child welfare data, our juvenile services data, and our adult sex offender data, and looked at future reports of sex offense. This is probably a confusing table. Does this have a, yes, okay, good. So let me talk a little bit. This is called a survival analysis. And so we looked at the kids over 10 years, and each one of these tallies down here represent a year. To survive means you did not get a report in any of those databases for a sex offense. So if half the kids had a sex offense, the line would go down to this 50%. And this is only half of it. So if all of them had, it would be off the chart down here. This top line that's dark is the child sexual behavior problem, cognitive behavior treatment. The dotted line underneath it is the comparison group. And the line down here is the play therapy group. This is 12 weeks of outpatient treatment. 2 take-home messages. One is all this white space down here. I'd say most of the public believes most of these kids are definitely going to be sex offenders. We need to put them on registries. We need to track them down and so forth. What this research suggests, 10 years later, most of them don't show a future sex offense. The other take-home message is that with the cognitive behavior group, they look no different than kids that never had a sexual behavior problem in the first place. This is 2% recidivism, 3% is for not recidivism for the comparison group. Where did I go? And 11% for the play therapy group.
What was the play therapy group again? Is that the kids, or that was just another group that you compared against?
These were a randomized clinical trial. So of the kids with sexual behavior problems, half randomized to cognitive behavior, half randomized to a play therapy group. So what the other take-home message is, this cognitive behavioral approach makes a bigger difference on outcome than a play therapy approach. And I'll talk a little bit more about the treatment outcomes about that, but first I want to see, are there any other questions about this? Is it clear? Is it confusing? Sometimes I get too statistically researchy. Yes?
It's clear, and I'm glad to see that, because there's a couple circumstances that I've been involved with that just scared me to death. I mean, I had a siblings, brother and sister, that were just screwing each other like minks when they were 12 and 13, 14 years old, and they finally got them separated. And now that the girl's kind of done okay, the boy, and he's landed down here in these judges' jurisdiction, he's continues to have problems with pornography on the computer, constant masturbate. I mean, but it's nice to think that his odds are good that he won't offend criminally, because that's been the biggest concern.
Has he received treatment?
Oh, yeah.
Okay.
The outpatient.
Outpatient.
And we had another one that the 2 gentlemen in the front row are familiar with, that we just got done with this week, that he was sexually abused as a child, and he's had inpatient treatment, and he just simply can't follow the rules, and he's just been committed to carnage. And when he comes out, I mean, I don't know. That's good to see, though. I mean, apparently, I would have expected much worse. But,
most audiences, in fact, I didn't ask you, but most audiences, if I ask before I showed this slide, what percentage of them do you think are going to reoffend? People say 50, 75%. I mean, that's why we have registration laws. And
Why do you think, I mean, because it seems to me these people don't follow the rules, they don't accept social norms, they don't, so are they just fearful of prison? Because they haven't hit that threshold yet.
no, I think, and I'll tell you a little bit about the treatment, and maybe that will help in explaining about what about treatment we believe works.
Clinical comparison, what is that?
The comparison group were kids without, so this dotted line are kids who've never had a sexual behavior problem but had disruptive symptoms. So they had ADHD or other behavior problems. And I saw them in a clinic for ADHD. These two groups, the dark line and the bottom line, are kids that have had sexual behavior problems.
And then you track them based on social security number and registries as sexual offenders in their adult lives.
Well, 10 years later, so they were 6 to 12, so 10 years later they were up to 22 years old.
Okay.
But after 10 years of tracking, we're not likely to see that suddenly that they would have additional ones in adulthood. But we can actually take these same things and redo it and see where they are now 10 years later after that.
You were about to say why you think that they don't reoffend?
Yeah, it's the treatment. Let me talk a little bit about that. And I realize I'm getting close to out of time. So they're diversed. And it's important to take into account the presenting problems when you're making treatment recommendations. So if they have trauma-related symptoms, being able to provide a trauma-focused treatment combined with a cognitive treatment for sexual behavior problems will be important. So you want to be individualized in your safety planning and treatment planning. The types of treatment that has been found effective have been relatively short, that don't use adult sex offenders. So if you hear them talking about cycles, about arousal reconditioning, those kinds of factors, that is not linked to effective treatment for children with sexual behaviors. That's an approach for adult sex offenders. And I'll talk a little bit more about what is important for the group for the treatments, or you can do this family-based. And that is caregiver involvement and doing behavior parent training with the parents. I've already gone through this. I'm going to jump up a little bit. So the treatment components, we've done a meta-analysis. So we took all the studies that did treatment outcome with children with sexual behavior problems, and we evaluated what are the components of the treatment that are related to sexual behavior problems reducing, to good outcomes. The major component is caregiver involvement and teaching the parents how to supervise and teach the kids how to follow rules and to communicate about these kinds of things like relationships and intimacy. So if you have kids with sexual behavior problems and you hear from the therapist that they're seeing the kid alone, they're not talking to the foster parent, they're not talking to the parent, I would be concerned. It's not going to work. This is not an in-your-head issue. It's the environment issue. And that includes the foster parents need this information. So the kid may have had sexual behavior problems with mom at home and now is in foster care. Well, it's not going to go away. The foster parent needs to know how to provide the kinds of guidance for them to learn how to follow rules. Behavior parent training is the treatment, also important for kids that break other rules too, and has been found repeatedly effective for that. The treatment needs to involve teaching what we call sexual behavior rules and boundaries. Also teach abuse prevention, because these kids are at actually about equal risk of getting victimized in the future than demonstrating future sexual behavior problems. So teaching them about risky situations, how to tell if someone is trying to break the rules with them, and how to get into a safe situation. Another key component has been sex education with the school-age kids. And honestly, in working with the families, I haven't found that teaching kids about eggs and sperm is what changes it. Rather, having the children and the caregiver begin to talk about intimacy, sexual manners, puberty, I believe by doing that in the therapeutic arena gives them permission to get that support they need at home. So when they see something on the internet or hear something from peers, rather than just reacting to that, they can go home and talk to their parent about that and make better decisions. And then with the school-age kids, we also work on empathy and accountability in our treatment work by having them, for example, write letters of apology, talking about the impact on the other people involved in the situation. Looking for qualifications of providers, you want them to be licensed providers, familiar with this research, and again, it's key for them to have active caregiver involvement. And I say that like that's easy. You know, okay, so you just tell the parents they have to come. These caregivers tend to have multiple barriers to treatment, logistical barriers, transportation, and so forth, but also just psychological barriers. You know, they think it's the kid's the problem, fix the kid, I'm not the problem. So you need therapists who, and agencies and systems that can help overcome the barriers. So it may be that it is going to be important to require the caregiver to be participating in treatment, including the foster parent. It may be looking at how can we overcome the transportation barriers? Can we find taxi or other kinds of services so we can get the caregiver involved? Can we be involved in supporting the safety plan? So can the safety plan be developed with the child welfare worker and the therapist so that we're all enforcing, this is what you need, this is the level of supervision your kid needs in order to make good decisions. And I mean, you guys have a fabulous foundation for developing great programs because you already are communicating interdisciplinary and being able to work together so that you're all on the same page about this is what the youth and the family are going to need for them to make better decisions and not break sexual behavior rules. So things when you're considering placement, how am I over time now? 3 minutes, okay. So what I heard from your description of the siblings before is that the young girl was having very frequent sexual behaviors, but then with outpatient treatment, she responded pretty well and was able to then make better decisions.
First you have to get separated from the brother.
Separate, yes, and that's key. If they are still in that situation where you're having that kind of frequent sexual behavior problems, having them separated will be key for them to then learn the appropriate behaviors, having then sibling sessions so they can learn to be brothers and sisters again, and being able to be reunified. And likely in part due to how frequent that behavior was going on. And also looking again at the degree of self-control and delinquency. The other youth you've talked about who was in inpatient, it sounded like there was a lot of other things going on beyond the sexual behavior problems. And when you put on top of that other trauma issues, depression, learning disabilities, even psychosis, then you're going to have more difficulty being able to maintain them in the community. Language barriers too. In being able to,
Immigration
that limits the resources, unfortunately, for families too. At least it does in Oklahoma. I'm assuming it does in Nebraska too. When making a decision to put them in inpatient and residential, at the time of placement, begin even that early to think about reintegration. And when is that going to happen? I worked with one family. The young man was 12, and he had sexual behavior problems with his brother who was 5. It involved penetration and repeated behaviors, and there was a decision that he go out of the family's home and go to treatment. However, he sort of got lost in the system. And 3 years later, he still wasn't back home with the family. He had been moved to another residential care and then to relative care across the whole state. Well, the 5-year-old brother was now 9, saying, "Where's my brother? I miss my brother." And we began working with them and was able to get the 12, now 16-year-old to move into relative care in the same community, did some sibling work, because they didn't know how to be brothers anymore. They hadn't seen each other in 3 years. And be able to then get that youngster reunified. He was very successful in his high school. There was no further problems with his brother. And that could have been done when he was 13 instead of 16. So trying to figure out how can you keep on track of those kids and not lose them and be able to reintegrate them, if they can be, safely back into the home.
Oklahoma doesn't have visitation requirements between siblings
Um,
when they're taken out home.
but it's based also on the, I heard earlier, safety.
Supervised.
They do not require supervised visits with kids that have had sexual behavior problems. I think they make the decision too conservatively. Quite frankly, this one situation I described earlier, the young boy who had the sexual behavior problem acted upon him, he didn't show trauma symptoms. Most of the symptoms he showed were related to missing his brother. If you look at what the court thought was, they wanted to protect him, and there was very good intention, but nobody actually assessed the boy to find out actually what he wanted was a relationship with his brother. And be able to, and so after, the mom just got us involved and we were able to assess and establish with the judge, in fact, one, the 16-year-old can be in outpatient, can be successful in the community, and two, the now 12-year-old younger brother wants a relationship and is not showing trauma symptoms. And the judge, in like an hour, I think, after getting that information, made the decision to get him to be moved so that we could look at sibling sessions and eventually reunification if it could be done.
This treatment format that you have listed here, is that the same for inpatient as well as residential?
In regards to the characteristics to be recommended?
Yes.
Yes, and the difficulty is the caregiver involvement part. Some programs have been very good at being able to really engage the caregivers, do family therapy, even though obviously the family's not going to live there. I would look at those more highly than ones that have absolutely no contact with the caregivers. Again, though, there's barriers. So can the system overcome the barriers to get the caregivers to be able to go to those family sessions? The other issue sometimes is what family is the kid going to. So the parents' rights have been terminated and there's not been an adoptive family. So sometimes the caregiver involvement is harder on inpatient because there isn't caregivers identified yet.
You'd probably look at where they're going to be returned to, like it's going to be a foster home, and have them be involved with the caregivers.
Exactly. Yes?
Some of the symptoms, and I don't know if you talked about them at length, but a lot of times we see like the encopresis and enuresis and the smearing and those behaviors. Now, are those sexual behavior problems or are those something else?
Enuresis and encopresis are not necessarily sexual behavior problems. They're not sexual behavior problems, but I have seen them co-occur with kids with sexual behavior problems. So we'll treat both of them, but it doesn't indicate that they have a sexual behavior problem and need this treatment. There are other treatments for encopresis and enuresis that actually work well and fairly quickly. The difficulty is most therapists don't want to deal with pee and poo, and so it's hard to find good treatment providers for it. But there are standard treatment modules that if the therapist is trained and can just follow it, it's pretty straightforward. It can respond to treatment. Yes?
Does your agency have homes that have these children in them, like foster homes?
Do we have foster homes with children with sexual behavior problems? Yes.
You run your own foster?
No, my agency is at the Health Sciences Center and we run outpatient treatment. We will work with therapeutic foster care agencies and train their foster parents, but we don't run, my agency does not run foster homes.
Because we have very few foster homes that wouldn't have other children in them. And so it would be hard to find a placement to do outpatient and that's not posing a risk to other children.
Well, that's a really good comment. These kids can be in foster homes with other children if appropriate safety measures can be maintained. And you've got to look at the individual child. So it may be a 9-year-old who sexually acted out repeatedly with his younger siblings, and he is then placed in a foster home where he can have his own bedroom. There is a 10-year-old and a 12-year-old also in the home, and you have caregivers who can appropriately supervise and have ways to monitor things in the evening and night. That kid could be in a home with other children and still be safe.
I
So,
think we have, the hesitation there is the huge amount of liability that poses, plus we don't have lots of folks that are willing to have youth that have sexual behaviors in their home with other children at risk to their own children. So we have that barrier. Their foster homes are rare to find placements these days, and so it's.
I don't know, do you have therapeutic foster care? Not anymore? Because I don't know if that's a possibility to if you can get, and that's what we've done, is work with some agencies where they identify foster parents who are willing to learn more. And oftentimes it's foster parents who've come through our program and realize, actually, of all kids in the foster care system, these kids are actually pretty easy to maintain once they learn how to supervise and monitor them. So we actually now have a group of foster parents who are more than happy to serve these kids in their homes.
The younger ones aren't. The younger ones have more possibilities than when you start talking 12, 13, 14, 15-year-old.
Yeah, adolescence is more difficult.
Just in general, adolescents.
Yes, adolescents are very hard to place in foster care in general, and a lot of times another challenge is they're being involved in delinquent services instead of child welfare, and so foster homes may not be available to them. I think that's a nationwide issue that needs to be addressed, is how do we serve?
The delinquents are in the child.
Oh, okay, okay.
So that's not.
From that example you just gave, are you saying that it might be important to separate the child who has acted out from the person that they were acting out with? You said you didn't say returning them to their home where they had where their sibling was that they had participated in this activity with. You said putting them in a different foster home with maybe similar age kids, but not back home. So is that an important factor?
Again, I would recommend that it be evaluated on an individual basis. Most of our kids in our program stay home with their siblings as long as the caregiver is on board with a good safety plan.
Maybe more the caregiver.
The caregiver is so essential. If you have a caregiver who's abusing drugs, clinically depressed, doesn't buy in, not interested, then you're going to be more concerned and you might have to think about placement decisions. If you have a caregiver willing, I have caregivers who are just shocked. They were so surprised by it and now are willing to provide the kind of supervision needed.
About the caregiver is feeling like their child doesn't really have the problem, or that there's something else to look at as well.
Again, yes, and sometimes they may need a temporary placement someplace else, like with a relative, but then you work with the parent, dispel these myths, and then be able to get the kid reunified relatively quickly. And I'm way over time. I want to show one thing is, and I'm going the wrong way. There is a resource that I think you would like to have. And that is, we wrote an article with Judge Stewart in Oklahoma County on children with sexual behavior problems, specific for how to manage these children in your court. And so this article might be helpful to you, that summarizes the information I provided today, as well as give some example safety plans and thoughts about when to make decisions for removal and reunification.